Good afternoon, everybody. This is Dr. Alipio. I'm going to start sharing my screen now. This afternoon's lecture is, we have two lectures actually. The first is Introduction to Psychiatric Disorders Due to Another Medical Condition. So if you don't know each other, let me just introduce myself a bit. My primary interests as a psychiatrist are occupational and organizational psychiatry and military psychiatry. These are my current affiliations. So I primarily work with Amang Rodriguez in Marikina, but I'm also a visiting consultant at two other government hospitals, and I do my private practice in Centuria in Makati. I'm also affiliated as a retainer psychiatrist for a BPO company, Task Us. So let's start our topic again. This is the title of this afternoon's lecture. So when we're talking about psychiatric disorders due to another medical conditions, we're talking about the psychiatric manifestations like psychosis being caused by another medical condition, depression, mania, anxiety, or other psychiatric symptoms manifested by or caused by another medical condition or substances for that matter. So let's start with psychosis. So psychosis, what's the definition of psychosis? If we were in a classroom, I would have asked you this, but since I'm not talking to anybody right now, I have to define it myself. So you've already discussed this, right? Before, I think. Psychosis is when an individual has an impaired relationship with reality, right? Or in more technical terms, impaired reality testing. What's reality testing? It's the way an individual interacts with reality, or like separating internal reality from external reality when it's presented to them, that an individual is able to distinguish between the two. So people who have an impaired reality testing can sometimes have difficulty differentiating their internal reality versus external reality, or they really cannot distinguish it at all. Okay, so it's a gradient or spectrum. It's not an all or none situation. So what are usually the symptoms that we see? What are the psychotic symptoms? What symptoms do we see when we say, to for us to be able to say that an individual has impaired reality testing or is psychotic or has psychosis? Okay, so like there are hallucinations, all right, or illusions. Okay, you have to be able to define that by now by your other lectures. Okay, what are the other stuff? Other symptoms? Delusions, all right. The realization, the personalization. No? If you don't know what they are, you have to research them. You have to go back to your previous lectures. Okay, but these are the psychotic symptoms, and when you see this, especially um, in a like together, it increases the chance that a person has psychosis. Okay. So now we talk about organic psychosis versus functional psychosis. These are older terms, but it's important in our discussion because it roughly translates into primary or secondary psychosis. Okay. So when we say primary psychosis, that's the functional psychosis. Okay. And secondary, this is the organic psychosis, meaning it's not being caused by a psychiatric illness per se, but being caused from the term secondary, it's being caused by another disorder, usually a medical disorder. Okay, so from this chart, you will see that, like when we consider functional psychosis, we usually think of schizophrenia or other schizophrenia spectrum disorders like brief psychotic disorder, delusional disorder, right? Meaning, if we take a scan of their brain or like take laboratories, take any laboratory test, there's a high likelihood that we won't find anything. Okay, unless like of course they have comorbid medical disorder, but that's not directly causing the psychosis per se. Okay, so the psychosis is existing on its own. It's like a primary uh, CA. Okay, when we say secondary, it could either be delirium from another, which is always caused by a probably like a metabolic cause or infectious cause. Okay, it could be from the psychosis from dementia, psychosis from medical illness, or psychosis being caused by medications. And this is also applicable to all the other psychiatric manifestations I was talking about earlier. So it could be depression from medical illness, depression from medications or drugs or toxins. So mania from medical illness, or if it's anxiety being caused by medical illness. So you get what I mean, okay? So that's actually the lecture's finished. That's what psychiatric disorder secondary to another medical condition is, right? Or secondary or drug-induced or medication-induced psychiatric disorder. Okay, to drive the point, no, just to drive the point to teach you how to distinguish between organic and functional psychosis. So usually organic psychosis has an acute onset. Okay, so like for example, if it's delirium, okay, or if it's, for example, very common example would be psychosis due to traumatic brain injury, for example. So the person has impaired reality testing due to having a traumatic brain injury or being in an accident, for example, or having a concussion. So suddenly they are confused and like they cannot tell what's real or not. Of course, that would have an acute onset. Okay, unlike functional psychosis, for example, the manifestation of psychosis in schizophrenia, it's usually like, what's the requirement for schizophrenia? Like 6 months, right? Or usually when we encounter them in the clinics, it's more than 6 months of having these symptoms. So the onset has been very slow, gradual over the years or months, and then suddenly there comes a point when like other people's around them cannot tolerate what their behavior is anymore, and then they bring them to you. Unlike a psychosis of organic origin, it's just like very fast, and they are brought to the hospital. Either they are brought to the hospital or the doctor due to the manifestations of the psychosis or because of the primary disorder. For example, they were brought to the hospital because of the traumatic brain injury, not for the psychosis per se. And then the psychosis just started when they were already at the ER or like en route to the hospital. Okay, so other signs or symptoms, neurologic signs may be present, a lot of times present in organic psychosis and absent in functional psychosis. The vital signs may be abnormal if there's a metabolic or medical cause for the psychosis, they will be abnormal, but are usually normal in functional psychosis. Okay. Short coffee break. Orientation may be impaired in organic psychosis and intact, right? So this is an important distinguishing factor, okay? Hallucinations. I'm pointing at the slides with my mouse, but I should be doing it here. So hallucinations. In functional psychosis, like for example, conditions like schizophrenia, the hallucinations are characteristically auditory. Okay? While in organic psychosis, it can be auditory, but usually it's not, right? But in functional psychosis, it's almost always auditory. So, for example, if the person is having hallucinations, visual hallucinations, you usually think of organic psychosis first. You rule out organic psychosis before you think of functional psychosis. And that's very important. Why? Because organic psychosis, you have to give attention to the medical illness that's possibly causing the psychosis, because it could be very dangerous to for the patient, right? It could be a life-threatening cause that's causing the psychosis. If the patient is in delirium, while in like if the patient just has schizophrenia, it's not that life-threatening. Okay? The condition might be more emergent or urgent if it's an organic cause. So what would be the most common cause for having tactile hallucinations? Withdrawal symptoms from substances. So that's organic psychosis as well, right? A very common example would be called something called a symptom called formication, not fornication, formication, where the patient feels like there are ants crawling on their skin. That's from alcohol withdrawal. Okay, so what are the most common causes of psychosis due to another medical condition? Right. So, well, I'm going to examine this like a clinician, like when we in the hospital setting. So, of course, like we'll consider first conditions that would probably be seen in the emergency room, right? And the most common would be, before we list it down, we have to learn about delirium. All right. These are the symptoms of delirium. Disorientation. What is orientation? Like we write in our mental status exam, right? Oriented to three spheres, to time, place, and person. So it's a test of the person being able to interact, or the awareness of a person to their environment. And a person or a patient who's delirious has limited capacity of awareness of their environment, because like they're confused. So when you ask them like, oh, nasaan po kayo ngayon, where are you now, they won't be able to tell because they're delirious. All right, so compare that to like a person who has a functional psychosis or like schizophrenia. When you ask them like, where are you right now, they might be saying something else, but they're aware of their environment. Do you get what I mean? Okay. If they're delusional, they could say, I'm in Disneyland, but that doesn't mean that they're disoriented towards, they're not aware about their environment. Compare that to a person who's like super intoxicated from an alcohol, delirious from alcohol intoxication. They would be able to tell that you've brought them from where they were drinking to the hospital. Limited awareness of the environment. That's what disorientation means, as well as like disorientation to time and to person. Okay, so they could have disordered thought process. They could have executive dysfunction. What are executive functions? You have to review that. All right, memory impairment. Memory is actually an executive function. Okay, visual spatial discoordination. All right, they could be agitated. Or you have to importantly remember that it's possible that instead of being agitated, a delirious individual could be like psychomotor, manifesting psychomotor retardation in hypoactive delirium. Not all, I'm not sure if like, are there students who are foreigners? Can I speak Tagalog? Hindi lahat ng mga delirious are magulo. Okay, some are not moving at all. And that's called hypoactive delirium. And this is, you have to be very sensitive about this, because it's dangerous if you don't recognize it. Okay, and some may manifest like frontal release signs or asterexis. I'm not sure if you should have like, if you should have studied this already, because they are signs of like toxic or sepsis, or what to call this, frontal release signs are signs when like there's a very there's a metabolic derangement. Okay, have to review that. So these are the most common conditions that we will see in an emergency room that we are concerned about. Psychiatric manifestations due to another medical conditions, and we're talking about psychosis. So the number one probably would be psychosis secondary to stimulants. Ano yung, when we say stimulants, ano yun? We're actually going to tackle this later when we discuss substance use disorders. So stimulants, pang meth, all right? Well, caffeine is a stimulant, pero siguro hindi naman kayo magkakaroon ng delirium due to caffeine overdose. Sobrang caffeine na siguro yan. Okay? So we're talking about most of the most common example would be meth here in our setting, or shabu. Okay, so psychosis from that. And like psychosis from alcohol use, alcohol intoxication probably. Okay. The next most common would be psychosis from hypoglycemia or electrolyte imbalance or other metabolic abnormalities. Okay. Or psychosis post-ictal, after seizure. That's very common. Right? Or during hindi pa nag-break yung ictus. Okay? Ongoing pa yung seizure. They could have psychotic symptoms. All right? And then all the encephalopathies. Okay? Even like hypertensive encephalopathy, if like a patient suddenly has a very high blood pressure and then binigyan nyo bigla ng you try to bring the blood pressure down very fast, they could have an onset of confusion afterwards, so psychosis. Or even during the height of the very high blood pressure, they could manifest with psychosis or delirium. Okay. Then, of course, like because it's an emergency room, we encounter psychosis following TBI. Okay. Minsan kahit concussion lang. Concussion is a form of traumatic brain injury. Yun yung pinaka mild TBI. Okay? Kasi even when you have a concussion, you could take an MRI, it could be normal, but there could be symptoms of TBI. Okay? How about in the ICU? So, the referrals that we get in psychiatry, pinaka-common, post-op delirium. Or even if they're not, sa recovery ICU ito, no? Even if they're not post-operative, then we call it ICU psychosis. Okay? So it's usually delirium. The manifestation is still usually delirium. All right? Usually like the residents would think like, baka meron siyang yung akala nila schizophrenic yung patient, pero it's onset, wala naman, no? Before they were admitted, they were like working as teachers or whatever. They were very functional individuals, and then suddenly magkakaroon ng schizophrenia. Walang ganun, no? So yan, acute onset. Tapos pag tinignan mo yung chart, baba pala ng niya, hyponatremic pala siya. Yung pala yung cause ng ICU psychosis. Or a common example that I see would be, kunyari an individual was talagang hypertensive siya before surgery, no? Tapos during intra-op, biglang the anesthesiologist probably was like trying to control the blood pressure. Nagkaroon siya ng hypotensive, short hypotensive episode. So nagkaroon ng hypoxia yung brain. Kaya pagkatapos, post-op, parang confused yung patient. Lito, yung pala yung nag-cause ng ICU psychosis. So we have to be sensitive about that. Okay? Other causes would be like medication-induced, and very common would be steroids given in the ICU or anticholinergics. No, some people, some doctors, when a patient in the ICU is agitated, they give diphenhydramine. That's one of the anticholinergics para makatulog or mag ano. But actually, it's very deliriogenic. So you have to avoid giving that. All right. Tapos withdrawal psychosis. What do we mean by it? Bakit magkakaroon ng ganyan sa ICU? Because like for example, imagine, kunyari merong patient was an alcoholic before. Alcoholic siya. Tapos na-admit siya for whatever reasons. Maybe like had a heart attack or like other reasons na COVID siya, na-admit siya. So before, every day siya umiinom, heavy drinker. And then suddenly, when the patient was admitted, so when we're going to talk about this again when we tackle the ward, what conditions could be seen in the ward? Pag dinala siya sa ward or pinasok siya sa ICU, of course, like how many days has he been admitted in the ICU, he's not able to drink. So after a few days, the patient will start manifesting with withdrawal symptoms. And one of the symptoms could either be psychosis, depression, anxiety, or mania. What we're talking about right now. Ayun. So akala naman ng mga the residents or the fellows in the ICU thinks like the patient has a functional psychosis or functional disorder going on. It refers to psych, but when you take the history, a careful taking of the history would reveal that the patient was a substance user before, and what's happening right now is the patient is manifesting with withdrawal symptoms. Okay, so later on when you become clinicians, if you're not interested in psychiatry, you have to be very careful about that. Yung mga ina-admit na yung pala hindi yun, you just ignore like whether that's why all parts of the history are equally important. You shouldn't miss any detail when you're doing an intake interview, because that detail might be the one that could make or break your case. Okay. Also in the ICU, symptoms like hypoglycemia, electrolyte, and other metabolic abnormalities. Of course, we talked about hyponatremia earlier causing delirium, causing psychosis. Okay, so let me introduce it now. Right, so learning about all of these conditions manifesting as psychiatric symptoms but being caused by medical issues, right? So what do you think would be the management of this? Of course, your priority is to address the cause. I actually don't know where to look. It seems like I'm talking to people, but like I don't have anybody who I'm talking to right now. It's just like, so weird. Anyway, so you have to correct. Like if it's hyponatremia, fix the hyponatremia. That would improve the mental state of the patient. Right? You don't like if the patient is manifesting psychosis. Of course, you could give antipsychotics for the patient's agitation to tone down so that you could do your management. Pero that would not solve the problem. You still have to address the cause of the psychosis, the real cause of the psychosis, because that would fix the problem. Okay? If the patient has seizure or like seizure in the ICU, of course, and also the encephalopathies, right? How about in the ward? Here, it would be more common to find medication-induced psychosis, okay, or withdrawal psychosis, as I was telling about earlier, right? O yan, pareho lang naman yung sa ward. How about in the outpatient? Okay, also medication-induced. Okay, or like maybe we'll find individuals who have in the outpatient have long-term seizure disorders. Minsan some of them they start having psychosis, like long-term psychosis. So that's a condition called schizophrenia-like psychosis of epilepsy. Like for example, patients who have long-term seizure disorders that are poorly controlled, no? They start having psychotic symptoms that are like are manageable by antipsychotics but never go away anymore. Parang nagkaroon na talaga sila ng skits. But it's because of their seizure disorder. Kasi imagine, like when you have a seizure, your neurons die, your neurons get damaged. Sometimes when people have seizures, they fall, so they hit their head. Nagkaroon pa ng TBI on top of their seizure disorders. So all of that things that those insults that are happening to the physical brain, ayun, nagkakaroon na sila ng psychosis. Okay? Kaya kunyari like yung mga boxers na laging nagkakaroon ng concussion, okay? Baka nawawala na sila sa reality nila sometimes. Okay? And then we have conditions like individuals with intellectual disability. This is mental retardation in the older classification. They could manifest with secondary psychosis, or in the patients with dementia, right? It could be Parkinson's dementia, or even if they don't have Parkinson's dementia, they could have psychosis. Lewy body dementia, very common to have psychosis, psychotic symptoms after a few months or years. Vascular dementia or from Alzheimer's, although Alzheimer's medyo, because it's a very slow, it takes a few years, no? So that's an organic psychosis that's not acute. Kung magkaroon man ng psychotic symptoms, no? That's one of the few examples na hindi acute yung onset. Pero but you will know naman kasi if it's Alzheimer's, no? Kasi hindi. Okay, so minsan magre-refer sa amin ng 80-year-old tapos parang nakalagay ng consideration schizophrenia, sumasakit na ulo, my goodness. Tapos pag it's obvious that the patient has dementia. Hindi pwedeng all the life of the person, umabot siya ng 80, hindi naman siya naging psychotic. Tapos biglang nung 80 naging schizophrenia. That's impossible. No? Kasi tignan nyo like ano ba yung usual onset ng schizophrenia. Oh. Hindi pwedeng gano'n. Biglang naging 80 years old si Lola or si Lolo tsaka biglang nagka-schizophrenia. Pwede, is it totally impossible? That would be like really, really, really hard to prove if that. Lalo na kung very obvious na may symptoms ng dementia yung patient. Okay? At the clinics, pwede ka tayo makakita na we could find psychosis secondary to CNS infections or encephalopathy caused by SLE. No? That's not a CNS infection, but I grouped it there because the manifestation is CNS. Okay? Metabolic causes and like tumors. No? Syempre, the tumors is most probably in the head or in the brain. Okay? So they could be primary and sometimes ang minsan na overlooked mets. No? Minsan we encounter a lot of referrals. Merong history of CA before, unlike that in the brain and other parts, tapos biglang suddenly after a few years may onset of psychotic symptoms. You have to be what do you call that? You have to have a good clinical eye, no? So pag ganun may history, it's just prudent, no? Magpa-scan ka kasi baka pag tingin mo ng scan, okay, sige, mag-light up pala siya. Meron palang meds and the meds could be causing the psychotic symptoms already. So hindi yun dahil nagkaroon na naman siya ng depression or schizophrenia suddenly at like whatever age they have, but like because of the meds that especially if they're like in the areas that are like in the frontal area where like all of these symptoms are coming from, di ba? Yun pala yung nagko-cause. All right? How about the more common medications that can cause psychosis? Okay? Steroids, all right? Lalo na pagka high dose and like it's being taken for a long time already. Stimulants, no, stimulant medications including ADHD medication because it's an analog of meth actually, amphetamines. Yung mga gamot, yung mga Ritalin. Okay, so baka pwedeng i-abuse. Tapos magkakos na pala ng psychosis. Dopaminergic drugs, no? So Parkinson's drugs. As you know, like psychosis is produced by hyperdopaminergia in the mesolimbic tract, no? And Parkinson's naman, on the other hand, is hypodopaminergia in the nigrostriatal tract. Okay? So you medicate individuals with Parkinson's, minsan kasi kapag napasobra na yung dopa drugs, baka mag-spill over na yon, pupunta na siya sa mesolimbic tract, that could cause psychosis, no? Lalo na pag in-overdose yung dopaminergic drugs. Kasi like all substance, yung mga illicit substances, they increase dopamine in the reward system. That's what makes us happy, but like pag sobra-sobra na, that's also what causes psychosis. Okay? Also interferon and anticholinergics. O basahin nyo na lang yung mga ano. Right? What are less common, no? Can cause psychosis, but that's not. I mean, like, mas common na ito na-encounter yung mga examples ko before. But this one, less common, but also could cause psychosis. So this is the list, right? So notice them, like, especially when you're going to go into IM. Okay? O yan, mga diet medications can cause. Okay? Antiretrovirals. Okay. Let me drink first before we continue on. How about depression secondary to medical causes, including depression secondary to substances? Okay. What are the common causes of organic depression? Again, I use the word organic, okay? Here. The most common condition we encounter is, or actually the top two would be post-stroke depression. Okay? Nagkaroon siya ng stroke, whether bleed or whether infarct, and then after some time, ayun. Usually, we get the referral from rehab na eh. They are doing their physical therapy, their rehab program, and then napapansin ng mga PT at saka ng mga rehab doctors, mukhang may onset ng depression, nire-refer sa amin. Very, very common that happens. So if you have relatives, if you know people who have like have had a stroke, you have to be sensitive and be aware para lang maagapan. Okay? So you could like intervene at the soonest possible time. Also, we get a lot of referrals for this is commonly called postpartum depression, but the correct term in the DSM is depression of postpartum onset. Wala lang, trip lang nila na ganun ng pangalan. But yeah, postpartum depression. So because of a lot of hormonal changes after pregnancy, at saka siguro yung tiredness and ayun, nagkakaroon ng depression. But it's organic dahil meron ng like pathophysiologic explanation bakit ganun yung nangyayari. So secondary condition siya. Okay? Depression secondary to dementia, to Parkinson's, to multiple sclerosis, to cancer, depression secondary to TBI, depression secondary to HIV or AIDS, from anemia. Okay? Severe anemia causing depression. No? That's not as common. Okay, so this list goes from most common to the least common. Okay, I don't know, haven't seen anybody yet with these conditions. Hypothyroidism should be higher on the list. Hypothyroidism causing organic depression. Okay, and depression secondary to SLE. Okay, how about meds? The most common one would be oral contraceptives causing depressive symptoms. antihypertensives, especially beta blockers and calcium channel blockers, causing depression, steroids causing depression, and like substance withdrawal from substances, especially stimulants, causing depression. How about mania? Right? Siguro naman, you know what mania is, what depression is, what the symptoms are. Okay, we won't discuss that anymore. The common causes of organic mania. Okay? Hyperthyroidism naman. Okay? Hyperthyroidism causing organic mania. Cushing syndrome, multiple sclerosis, neurosyphilis, mania secondary to seizure, either usually like post-ictal. Okay? Mania secondary to TBI. And these are the medications. Notice, dito, yung tuberculosis medication, especially isoniazid, that's how I remember it. Isoniazid can cause mania. Okay? How about anxiety? So I also listed the hierarchy from the most common psychiatric condition secondary to a medical cause, from most common to the least common. So psychosis is most common, then depression, then mania, not that common you encounter, and then anxiety, hindi rin masyado ganun ka-common. And then like the others, like rarely would you ever encounter that. Okay? Common causes of organic I